Welcome back to the Sickle Cell Society podcast. We're sponsored by Terumo. Today, we'll be joined by the head of obstetrics at Guy's and St Thomas's Hospital, Professor Eugene Obteng-Intim. I'm your host, Kesua Brown. Let's get into it. So, Eugene, you're a specialist in women's health and sickle cell. Yes. I'd love to know what advice you give women who have sickle cell or sickle cell traits when they come to you and say they want to start a family.
Thank you. So, I think I will start off particularly with women living with sickle cell disease or with the experience of sickle cell disease. Often we will ensure that they come knowing or planning pregnancy. Clearly, in this country, 50% of women will have unplanned pregnancy. So specifically for sickle cell disease, it's important if we can plan it. It ensures that they may be on certain medications, which we may advise that they stop. It's important that we manage to stabilize their condition very well. So that may mean checking the liver, checking the kidneys, checking the lungs and the heart. And by and large, if that requires treatment, we will advise that we manage that first before they come into pregnancy. It's important certain vaccinations may be given, and that may include chest conditions such as pneumococcal vaccine, flu vaccine, and clearly COVID has gone away, but actually COVID vaccine too. So any vaccination we can give prior to pregnancy is very, very important. When they come into pregnancy, the key thing is to have a multidisciplinary team looking after them. So that may be their hematologist or doctors who specializes in blood conditions, their obstetrician, and importantly, perhaps a team of midwives or a midwife with the knowledge about sickle cell disease. We then make a clear plan. So sometimes during pregnancy, they may come in crisis, but if we've got a clear plan about their pain management, then any clinician they will come to, they just show them, this is my pain management. Then within half an hour, that will control their pain and they're not waiting for very long. Usually it's important, particularly in pregnancy, for a senior person to see them within 24 hours. So ensuring that they get to a place where they will be seen by a senior person in time will make a huge difference. We also ensure that the growth of the baby could be well monitored. So we often from 20 weeks advise for 4 weekly scans. And we ensure that conditions that may be prevented, such as they are prone to hypertension in pregnancy, having small babies in pregnancy. And we know giving low dose aspirin, 150 milligrams once daily during pregnancy, will improve that by 50-80%. So that becomes very, very pertinent. And giving anti-clotting medication or assessing them who needs anti-clotting medication prevents the risk of clot. That's also very, very life-saving. So there is really a lot that we can do for pregnant women who lives with the condition, planning pregnancy and during pregnancy. For those who are carriers, it's important to check whether the partner is also a carrier. If the partner is not a carrier, they will usually have normal pregnancy and behave normally. So there's no concern at all. We treat them as normal. If the partner is a carrier, then they have 1 in 4 chance of having an affected child. And again, we will advise that what we call pre-implantation genetic diagnosis, that is IVF. And once we egg and the sperm fertilized, the embryos are then identified which of them have sickle cell disease. We freeze those without sickle cell disease and we transfer those one at a time, or as much two at a time, because we want to minimize the risk of twins. And we freeze the rest. Success, I've alluded to, is about 63%, and they can always come back for subsequent babies to use those embryos. And actually, the important thing is that it provides for that child a generational cure for a long time, particularly if we transfer the ones with AA, then that generation, it provides a cure. So it's actually important to make couples aware of this, either where they are carriers or where the mother, father may be affected, but with a carrier partner.
Thank you for sharing that with me. And you spoke about IVF there, and that you work with women patients who have gone through this process. But I know that IVF isn't currently free for everyone with sickle cell. So I'd love to know a bit more.
You are right. Cost may be a barrier to some couples. What we have argued for is for this to be funded by the NHS, and it is indeed funded for most couples in terms of those who are at risk of having an offspring with sickle cell disease. It's funded if, one, they have no children at all, and two, if they have an affected child. So if they have unaffected child, then currently they are not entitled for it. But we are trying to make a case that actually it should be free for all who are at risk of having an offspring with sickle cell disease.
Yeah, well, no, thank you. That sounds really interesting. And I know that you spoke about IVF there, and how with this process it means that generations after might not have sickle cell. So what's the difference between IVF and gene editing?
It is very, very important. There is a huge distinction. So IVF and diagnosing from the embryo unaffected embryos is called pre-implantation genetic diagnosis. So before that embryo is transferred, you make sure it hasn't got the affected gene, i.e. the sickle cell disease. So that almost, as I said, provides a generational cure. Gene editing, i.e. after birth, with a child who is affected, we then take perhaps stem cells from their bone marrow, edit their genes, i.e. the sickle cell anemia genes, edit that to perhaps unaffected hemoglobin AA gene in the lab. So we take the bone marrow in the lab, edit it. Actually, we have to prepare that patient by giving chemotherapy to wipe away those affected stem cells, and we put back the edited stem cells back into the body to then produce hemoglobin A genes. To be able to be successful with that, we have to ensure that we give chemotherapy first. That requires a good counseling, because when you wipe out the bone marrow, there's a risk of infection. So in a small proportion, maybe 1 to 2% these days, there is a significant risk that we minimize, and hence is done in very few centers. Clearly, that process can be quite expensive, and at the moment is not fully funded by the NHS. What it is available, perhaps a bit more, in about 10-20% of the time, is using perhaps a sibling donor called hematopoietic stem cell transplant, where you find perhaps a matched donor. So you don't need to edit. You wipe out the recipient's bone marrow, those receiving the donor cells. bone marrow and then transfer unaffected matched donor marrow to that individual. That's a lot cheaper, that's more widely available, but it can only reach 10-20% of patients living with sickle cell disease. So the gene editing can be more widely available, but actually so expensive. At the moment, it's about £2 million. So we really have to find a better way where we can provide a cure. But actually, these 2-3 approaches is providing a significant hope for the future cure for sickle cell disease. And I think it's so important in this country, globally, for us to do more research to focus on a cure. After all, sickle cell is actually the first condition to be genetically identified, over 50, 60 years ago. So actually finding a cure in this condition becomes so important.
Definitely, and I think when it's the fastest growing blood condition in the UK, I definitely think that garners a bit more attention. Do you know what I mean? I think obviously some patients do feel like it doesn't really get spoken about much, despite it being such a big, genetic condition in the UK. And I think it is really interesting that we are seeing the growth of these kind of medical advances in sickle cell, and hopefully, like you say, they're available, more widely.
Precisely.
Yeah,
Thank you.
yeah. I'd love to ask you about hydroxyurea, because I do know that a lot of patients take that, but when they're wanting to start a family, their doctors advise them to stop. Is there a reason why?
Yeah, that's very, very important. So hydroxyurea is actually one of the most, if not the only most effective drug for treating sickle cell disease. And it's so important for our patients living with the condition because it reduces significantly the frequency of sickle cell crisis. So actually, being at university, being at work, it actually means that they can almost live a good quality of life and being able to move on. So it's so pertinent. Clearly, one key thing is that most medications, the trials are not done in pregnancy. And that actually impacts on women's health in general. So if a couple wants to become pregnant and they're on hydroxyurea or hydroxycarbomide, they really, because we don't know the effect or the impact or the safety profile in pregnancy and the impact on the unborn child, we often have to advise for them to stop whilst they are planning pregnancy, and also if they become pregnant on it, to stop. Clearly, for some mothers where it may take time to become pregnant, you are saying for 6 months, 9 months, they stop this important medication, which really helps with their quality of life. But I think perhaps at the moment, whilst we don't know the effect, the safety profile on the baby, is the right thing for us to do. We need to do more work, we need to collect more data, but the advice now is yes, to stop it. If they are on it and they become pregnant, to stop it, but to continue. As we get more data, it may be that we will advise stop it first 12 weeks of pregnancy. If a mother is severely unwell with frequent crisis, or perhaps we can use blood transfusion because they react badly to blood transfusion, then we may be only left with hydroxyurea, hydroxycarbomide. But with multidisciplinary discussions and care, and clearly ensuring that the mother couple are well informed, they may choose that this is the only option for them. And in that case, on those individual basis, we can consider it.
I think that's really interesting because that's obviously such a big thing for a mother to think about, when she's carrying her child. And I think as well, when we look at statistics when it comes to Black maternal, death, like maternal motherhood, we see that, Black women are 4 times more likely to die during childbirth. So if I was a sickle cell patient and I already know this and I feel like my pain is ignored, maybe sometimes nurses aren't listening to patients, I can't take the one thing that kind of makes me feel okay. It must be so worrying for them at times.
It is, and I think in perhaps these situations, it's important to build the trust because it's very, very worrying for the patient. And that means that ensuring they have continuity of care with the midwives. Very importantly, the sickle cell nurse who may have been involved in their care for a long time pre-pregnancy, some actually from childhood onwards, some through the transitional care, becomes a hinge pin. So they will often have their mobile in pregnancy. They're able to ring them and discuss some of these challenging issues. And as doctors, ensuring that we bring in the nurses, the midwives, the community nurse, the blood doctors, and be able to discuss this with the patient right at the center to perhaps provide that personalized, precise care for the couple, for the mother. And I think this becomes very good experience. It's not provided everywhere, it's not provided all the time, but if we are able to build trust and actually ensure that the care 100% across board, awareness for the condition to all midwives in terms of training, I think we can make a huge difference. The system really have to change to address the 4 times more. And I think there is a lot of work that needs to be done within the NHS for us to move that forward.
Thank you for sharing that with me. And I think, when it comes to family planning and, couples, I definitely think we throw sickle cell into the mix, and I think sex and relationships amongst the Black community is very taboo, and I think it's even more taboo when sickle cell is present. And I'm just wondering, when it comes to the men, have you heard from them about difficulties maybe men with sickle cell have had when they're trying to plan with their partner?
It is very, very important because clearly in the wider society, within the health sector, within schools, social in general, sadly, there's a stigma attached to sickle cell disease, and how our patients navigate through this could be very, very challenging. And I think it's important so much for us to improve awareness at the schools, community health in general, and also particularly access to the NHS becomes very, very important. And I think at a crucial stage in a patient's life living with the condition is very, very important for us to ensure that that stigma is removed. How dating becomes very, very important. At what stage of the relationship do you let the partner know is very, very important. And I think us being confident and also empathetic in those stages of life becomes very, very important. If we are able to overcome that through relationships, clearly there are perhaps concerns with regards to intimacy, intercourse, and the impact particularly in the males, often concerns such as Priapism, and that is in relation to perhaps sustained erection for 30 minutes, for more than 30 minutes, and how that is dealt with. And it's important, perhaps, the good rapport with your sickle cell team is important to make the patient aware of this before perhaps that stage, and also what to do to alleviate those symptoms. So, for instance, when that were to happen, it's important to ensure that simple things like taking paracetamol, being able to drink water, sometimes the need to maybe go for a run may make a difference. But if it goes on for more than 2 hours, that may require the need to go to an emergency to be cared for. And that will require perhaps the need for the blood doctors to be involved. Sometimes we do give medication to help. And very, very occasionally may require surgical treatment by perhaps who we call urologists, specializes in that scenario, but it's very rarely do we require surgery. And often those self treatment make a difference and be able to help. And often, if it's a long-term partner, if they are aware, actually they're extremely empathetic and able to go through that aspect of life very, perhaps not as challenging as it could be.
So Eugene, it's been so fascinating talking to you, but I'd love to know, how do treatments that sickle cell patients have affect libido, fertility and sexual function?
Yeah, so I think taking the libido and sexual function first, the key is ensuring that the patient have less crisis, and hence their quality of life is good. Clearly, if the quality of life is good, there isn't much of an impact of sickle cell disease on the experience and lifestyle, then actually libido and sexual function will be automatically fine. One, they are not in hospitals a lot. Two, they are getting on with their daily living, and hence actually their well-being is good. So libido and sexual function is very good. Certainly the less crisis, such as using medications such as hydroxycarbomide, will mean that their frequency of crisis, including priapism, will be very less. So as a result, libido, sexual function will be just as any other person. So very, very important. The frequency of crisis may be controlled by blood transfusion, or what we call exchange blood transfusion. And that means perhaps removing the sickle cell and replacing it with usual blood cells. And in that scenario, for some patients living with the condition, that is actually what is best for them. And they carry on normally. We have patients who may live abroad, but every 6 weeks come for their treatment, carry on with their normal life. And that includes normal sexual function, normal libido. Clearly, enhanced hydroxycarbomide exchange blood transfusion, very, very pertinent, and actually makes a huge difference to some patients who may have been on these for years, and they live a very good quality of life. With regards to fertility, that is an important one. So hydroxycarbomide, we really don't know the impact on fertility. It will be very, very mild because there are a lot of patients who may be on it where perhaps we measure a hormone that called anti-Mullerian hormone, which is a measure of ovarian function or perhaps testicular function as well. And we are finding that the AMH may be low. This may be as a result of the condition, or it may be as a result of the hydroxycarbomide. We really don't know. So I think when it comes to a time where a patient or a person living with the condition is planning pregnancy, we often do advise to stop hydroxycarbomide. And we say that continue to seize on it during pregnancy as well. We have published for the first time actually a measure of this hormone for patients living with the condition. And what we are advising is that whilst perhaps 20, 30 years ago, I may see only 5% of mothers over 40 having pregnancy, now I'm seeing 20%, even in the general population. We will advise that for patients living with sickle cell disease, particularly women, don't live your reproductive life till late, or fertility planning pregnancy till too late, because the ovarian function may go down as a result of the condition. But the treatments such as hydroxycarbomide may even compound on that further. So don't live pregnancy till too late. Secondly, for exchange blood transfusion, actually it has no impact on fertility at all.
That's probably really reassuring for some sickle cell patients.
Precisely.
Yeah, so I'd love to ask, how soon after giving birth can women go back on hydroxyurea?
Not very long, because there's very minimal impact or virtually no impact on breastfeeding.
Okay.
So actually going back on it, usually we advise they go back to see the Sickle team, certainly in the UK, 6 weeks or so, and often they would advise them to go back on it after that. They can use hydroxyurea, hydroxycarbomide with breastfeeding. There's no issue there.
That's good to know. I mean, I feel like after they've pushed out the baby, it's probably a relief to know that they'll be able to go back on their pain relief shortly after.
Precisely.
Now, Eugene, people have written in with their dilemmas, with their questions. So I'd love to kind of discuss them with you. Can we do that? Is that okay?
For sure.
This question is for someone who's 45 and they've written on behalf of their daughter who has sickled cells. Now, she's currently on a hydroxyurea, but she wants to start a family. What can she do? I think we've, discussed that, haven't we?
Yeah, that's right. That's very, very important. And it is good that to ask this question at this stage, because interestingly, hydroxyurea is the most effective drug, perhaps the only drug that we've really got for treating sickle cell disease. So answering this question impacts on a lot of patients living with the condition. Our current advice is that if they are planning pregnancy, to stop hydroxyurea, but it's important for her to discuss with her team of doctors who usually will see her at least every year. And stopping it may actually increase her frequency of getting crisis. So there is then a plan in place whether they switch to exchange transfusion during that period. And by and large, if she's trying for within a year, there's 80% chance that they will become pregnant. So hopefully they wouldn't have stopped it for long. When they become pregnant, they should continue not to be on it, because the reason for stopping is that in the studies not done in humans, but in animal studies, there may be a suggestion that it may impact on the developing organs of that baby, that fetus. So for caution, they stop it. If in pregnancy we have concern, we can think of exchange or blood transfusion. So we have a different method to look after them in pregnancy. And then after delivery to then go back on it. But this has to be discussed with her team, and depending on what is best for the daughter, they will have a good plan, clearly with the daughter being right at the center of the decision making.
I think that's a very comprehensive answer. So thank you,
No
Professor Eugene. Someone's written in, age 30, how to reduce the painful and stress part when it comes to planning a baby.
The key thing is the planning. Often, usually, again, her team of nurses, doctors should be able to help navigate the challenges, the stresses of planning pregnancy and becoming pregnant. I think it's important to say that almost all patients living with the condition will be able to have a safe pregnancy. There are only very small scenarios, particularly those with pulmonary, what we call pulmonary hypertension, i.e. where the condition have affected their heart so much. And this is why in most of the cases, particularly the women, we do echocardiography to screen that the heart is fine. By and large, where that is fine, anyone should be able to become pregnant. And we plan that pregnancy as to what to do in different scenarios. Have a multidisciplinary team that involve obstetricians, midwives, nurses, specialist blood doctors, and be able to see them regularly. Also ensuring that there is a good rapport with that team, particularly with able to contact the nurses very regularly. And then with that regular review, with growth scans, monitoring the baby as well, most patients living with the condition will be able to have a successful pregnancy, a successful outcome, and a good experience.
That's really reassuring to hear, actually. Yeah. Well, thank you so much, Professor Eugene. Someone aged 31 has written in, what effect will pregnancy have on my avascular necrosis in my hip? They're worried that they will not be able to carry a baby due to the weight and pressure it places on their hip. Any advice, any tips?
Yeah, so perhaps I'll follow on with the last question. I think one important thing is for our patients living with the condition to be able to find out centers that really are dedicated to looking after them in pregnancy. And most centers in the UK can do that. They are linked often, even if it's a remote hospital, linked with specialist centers. So they should ask that question. Would you ensure that I'm linked with a specialist center that looked after sickle cell disease? That's very, very important. For specifically answering that question in terms of avascular necrosis and sometimes hip replacement, carrying the baby will be fine. It shouldn't be a problem. So we will be able to look after her without much concern. They may, just like they may have crisis anywhere in their body, they may have crisis in the femur, in the legs. And again, that will be looked after. Where there is a slight challenge is perhaps position to deliver the baby. And in some scenarios where it may be challenging to part the legs for the delivery, we will assess so that we don't compromise that hip. And occasionally it may require cesarean section or perhaps different positions where the unaffected leg is fine. Lie on that side and parting the legs till, again, she'll be able to say, not that far, we will assess that and then ensure a normal delivery. But in some scenarios where it will be challenging, then we'll deliver by cesarean section. But carrying the actual baby throughout the 9 months of the pregnancy is by and large very safe.
Okay, thank you. And I guess, so it's very safe for the baby to be carried for over those 9 months.
That's right.
And also the medical team will kind of find something that works for her when it comes to delivery.
Precisely. That's actually so important. That personalised care is so crucial.
Okay, that's really useful to know. Thank you so much, Eugene.
No problem.
And someone has asked a question about intimacy. Now, they've asked, can sickle cell cause pain during sexual intercourse?
It shouldn't do. Clearly, we have to ensure we've provided a good advice to alleviate any anxiety for that person. It shouldn't really do, because that activity, if anything, where it may minimize their stress. So it shouldn't really do. I think that a good education, a good awareness to alleviate any anxiety is fine. Generally, with intimacy, actually getting to know yourselves as a couple makes a huge difference. So appropriately ensuring that the partner perhaps know a bit more and you're able to naturally relax in that environment may alleviate any concerns, anxieties. But the actual condition should not impact in terms of crisis at the time of intimacy.
Do you think if that does happen, or if it happens more than once, should that person go see their GP or specialist?
I think it will be helpful, because actually being able to talk through this and being able to be reassured that the condition may not be an issue in it, may in itself be enough to actually calm that person, because living with the condition, there are a lot of taboos, and I think sometimes seeing a professional about it is so important, because what family members may say, what the stigma one may have experienced, may actually impact on that. So seeking a professional in time, such as a GP, such as the Sickle nurse specialist, will make a huge difference, but it shouldn't impact on intimacy at all.
Okay, thank you very much.
No
Thank
problem.
you.
Thank you.
You've been listening to the Sickle Cell Society podcast. Today we were joined by Professor Eugene. We're sponsored by Terimo, and stay tuned for next time.